Is the microphone working?
Yeah.
Great to be here today. I want to talk about what's upstream of artificial intelligence, machine learning, and healthcare. And I use three words that people like to use: so cash, money, profits, and agency. And whether that agency is given to the patient, like we talked about with the NIH director, or whether that profit and money and improved or reduced agency or decision-making capacity is given to the system, whether that's payers or pharmaceutical companies, life sciences companies, hospital systems, doctors. So these are three words I think about a lot when I think about developing artificial intelligence in healthcare. Let's see if the clicker works. There we go. It's the slides are not changing. Do we have any idea why? You have the same thing? Double click. So it says I'm screen sharing. Maybe I need to share the whole screen.
Yeah, no.
Let's try. There we go. Okay. So I'll take a page from Dr. Martin's presentation from this morning. I'll start with my grandma because the room loves grandmas. I was in Estonia 2 weeks ago. That's where my family's from. And she's 94 now. She's doing okay. She wasn't always that happy. This other photo is her at age 17, and she's about to be sent off to the Gulag, Siberian concentration camps, because of political activism. So again, I come back to the word agency of if somebody takes certain decisions and the government doesn't like them or a system doesn't like them, then do they get their agency and freedom taken away? In this case, for 14 years. Then she got out, had my mom and 3 other kids. And so that's one story that comes to mind, and that's the reason I'm in America. And I love being in America. And sure, thank you. I love moms. This is my mom. This is the daughter of the previous person. And my mom also comes to mind when I think about agency, decision-making capacity, and healthcare, because I've seen her raise 3 kids, 5 kids if you count my older brother and sister, who were there when she moved to Canada in her 30s. And I still see how she's treated so differently than I am. Like I've had to do speech therapy to work on my American and Canadian accent, because I still can't pronounce the word R properly. I've done improv lessons, singing lessons, like everything I can think of just to fit in and try to reduce the cognitive dissonance of like, am I different or am I a product of my mother? And I see how effective it is to say work on my accent to try to give this speech. And my mom, it's a lot harder for her. She's in her 60s now, and she still gets shit from doctors when she goes to the doctor, and it's very different. When I go there, I'm like, hey, I'm Dr. Jan Albasar, what's going on? So now back to Fort Worth, because the reason I'm here is because of this third person. I'll advocate on whether they're a man or a woman to protect their privacy or a they them, a non-binary pal. So they live a couple miles away from here. I committed them to the John Peter Smith hospital system 3 years ago. And I saw what it was like for somebody with no health insurance, schizophrenia, serious mental illness, no money, no remaining family. And I helped them find a group home and had to do all of it with the help of me and a few friends. They're just family friends suffering from schizophrenia in their 40s, let's say. And I saw them on Sunday, and they still keep calling me. They say, hey, can I leave this group home? I get hit in the face by like a nurse's boyfriend. And then when I get a call like that, there's no one to call. Back to incentives, because if I call the cops here in Fort Worth, they're going to say, we can't really do much because we need to keep sending people to the group home. And if I call the hospital, they'll say the same thing. We need to keep sending people to that group home. And if I talk to the group home owner, they're making $740 a month times 30 people per group home, times 5 group homes. They drive a Mercedes, and all they need to do for the in-kind support that Medicaid requires is provide 2 meals a day and housing. And so it's quite a good deal if you're the group home owner, but it's less good of a deal if you lack agency and you lack decision-making capacity, like this person who's a couple of miles away from here. And they see a psychiatrist maybe 5 minutes a month, and that's about all they get, no therapy, nothing. And it's really hard for them to use technology. So like I was trying to show them how to send a voice memo on WhatsApp, but it was really hard to press that button, no matter how many times I did it. And so then again, I think like, wow, I can use speech to text, but is this person ever going to get the same agency that I feel when I use technology or when I think about building machine learning to support health disparity? And until you see it with your own eyes, it's easy to keep it in the box. But once you work with populations that really, really lack agency, whether that's in the eyes of the law, in terms of serious mental illness, it really hits home. Like, is any of our work ever going to be useful for somebody who sent me a text message for the first time this year in their 40s? It's really, really hard to get to reach the populations that we may want to serve who are extremely marginalized in America and around the world. And so I think Allison is here. Thank you, Allison. Allison Christian taught me this this great metaphor as we were discussing yesterday. This is a river, and I like this framing because this is apparently like a standard public health thing, where the people might be drowning in the river, like say people like my family friend, and then who are the first responders? It might be a doctor jumping into the river, or it might be a nurse, it might be a family member, it might be their family taking them down. And then who's one level up? It might be the cops, or it might be the hospital system. And the further upstream you go, the more you think about, well, what role are the social determinants of health playing in the downstream decisions? And I really like this metaphor, thank you, Allison, because I think it encourages thinking about things from a bird's eye picture and then understanding how best we can build the machine learning statistics, epidemiological techniques necessary to tackle things at all scales, because it's not going to be solved from the bottom, it's not going to be solved from the top, because again, until you see it with your own eyes, you're going to just keep the 1% of people with schizophrenia in group homes in and out of the system, frequent flyers. And so when I was preparing this, I was thinking about whether we could use this great river analogy to think about the flow of data, where who has the most data? It's probably the person themselves. The patients have the most context, they understand their experience, but then they go to the doctor and the amount of data gets smaller because they have to talk, or they have to give their blood, or they have to give some kind of reduced representation of their patient state. And going one level above doctors and hospitals, then you have HIE, CCDA, these are health information exchanges or consolidated clinical documentation architecture vendors. And this is a $50 billion industry. This is huge. And they contract with hospitals to improve patient care and turn around, sell the information to, like, say, de-identified patient records to pharmaceutical companies and life sciences research. And I still don't know whether my data is going to HIEs, because it's really hard to figure this out as a patient. I've tried spending hours and hours on the phone at each one of my hospitals, and it's still hard to know which HIEs does Columbia University Irving Medical Center, my employer, contract with, or New York Presbyterian Hospital, or Weill Cornell Medical College. I'm a patient at all these institutions, but it's still hard for me as a patient, as an employee with an office on the top floor of the hospital, a little ironic, to figure out where is this data going? Did I consent? Did I not consent? And we're only at stage 3, so we'll keep going. So then we have insurance companies. The insurance companies, they'll contract with many different HIEs, whether that's Health Verity or other big ones, other CCDAs, and they'll try to figure out how do we pay the minimum amount. And so already we have this battle going on of, like, the doctors trying to cover their salaries, trying to cover their department's costs. Some departments are loss leaders at the hospital, like the OB, and then obstetrics and gynecology, they might start doing C-sections, elective surgeries, to start covering the cost of the revenue loss. And so already you have this really complicated landscape of data that's tied to cash, that is tied to somebody's decision. So if you know people who have struggled to not get a C-section, have a vaginal delivery, then it often helps to frame it in terms of data and frame it in terms of cash and frame it in terms, if they happen to be on Medicaid, then think about, well, if a C-section pays the same amount under Medicaid as induced labor, then what's a doctor to do if they're getting yelled at by their CEO because they're losing money in the OB department? So these are just some anecdotes to illustrate how data gets less and less complex as you go up. You start losing that one-on-one nuance of, say, my grandma or my mom or my family friend here in Fort Worth. And then you have the pharmaceutical companies who work with everyone so far. Like they try to help patients, they try to do drug discovery. It works sometimes. For me, it worked with Cymbalta. It's awesome. But again, I don't know how much I'm subject to advertising, which is a big part of revenue in pharmaceutical companies. And then you have the regulators at the very top, which have the least amount of data because it's being so compressed at every step of the way to try to have population level health outcomes, to try to adjudicate, well, what should Medicaid pay for? Some states are starting to pay the same amount for C-sections and induced labor, but that's a state-by-state decision. It's really, really hard to do this research and compress the data so one human in one room can make one decision. So that's just to illustrate at a bird's eye picture what part of the landscape looks like when you're thinking about health AI. And Dr. Prosperi's presentation was extremely helpful because now we can think about the confounding variables here. If the government is trying to get access to the data, if pharmaceutical companies are trying to get access to different data, if payers are trying to pay the least amount, HIEs and CCDA, they're trying to get all the data, and then hospital systems as well are trying to outcompete each other. Then you can start thinking about where are the confounding variables? Like the moment somebody's trying to do something and data gets collected a certain way, instead of being independent and identically distributed, then it's really hard to draw conclusions about clinical endpoints, about health outcomes, about health disparity, when every step of the way in this data stack, you have humans making decisions according to a certain goal that you can't measure. You don't know who's out to make money, who's out to improve patient care. You can ask somebody, but then you don't know if they're lying to you on the self-report questionnaire. So the confounding effects throughout this stack of data as it flows through the system are very, very strong. So personally, I like trying to work across the stack just so I can keep some of those confounding effects in my brain as I talk to different people, whether that's patients, providers, insurers, HIEs, pharmaceutical companies, or regulators. So now that we covered data, let's cover some cash. We all need more cash, especially the patients at the bottom. And cash, unfortunately, looks a little different than the data stack. So back to that question yesterday of like, if somebody consents to release their data, do they see any of the profits generated by that data, generated by that valuable healthcare artificial intelligence or machine learning? So now we can go in reverse. We can think about the regulators. They usually have the most cash. Hospitals try to have a healthy payer mix of sometimes public, sometimes private money, but these are big pockets. So people go after that cash. Pharmaceutical companies as well. Pfizer made like $50 billion on the Pfizer COVID-19 vaccine. So they're doing pretty well. Payers a little bit less because they're responsible for trying to pay the least. So it's quite intense if you're a payer these days. Then you have HIEs, these clinical document aggregation services, health information exchanges like Health Verity. Then you have the actual doctors. Some might be salaried, some might not be. Some might get RVUs and bonus points for complying with clinical documentation, improvement efforts. And then you have patients at the very bottom, at least usually. I haven't seen any scheme that tries to flip this a little bit more. And I think it's just really, really hard when you have all these incentives and all these deep pockets stacked on each other, and you cannot measure the confounding variables in any kind of correlational analysis you want to do to understand how, say, health disparity is related to the amount of cash available in a certain neighborhood. So now we can think about those two streams that we saw. One was going upstream of like compressing the amount of data, starting from the patient level to the provider level to the government level. And we could think about whether we can map this out and whether we can try to get at some of the unobserved confounding effects and start drawing these causal graphs that are going to be necessary if we have any hope of addressing health disparity within our lifetimes. Here's all the nursing homes in the United States. This is public data. You can download it. It's a CSV file of 15,000 rows distributed across the states. And this is a huge real estate money-making deal. There's big private equity firms that try to buy conglomerates, try to use technology like artificial intelligence and machine learning to reduce staffing, optimize numbers, optimize the number of beds, do the exact same things that hospitals are doing, and try to improve patient care at the same time. It's a really hard problem if you're a private equity firm and you need to convince your investors to give you the next $2 billion fund in a few years. So it's challenging to use technology to optimize both healthcare and profits. And as one initial study with the foundation that we started this year, we collected somewhat public data on assisted living facilities, like the one this person in Fort Worth that I've been trying to help out lives in. Because when they call me, they always ask like, hey, could I go to another group home? Could I go to another group home? And so I'm like, I've spent thousands of hours of my life trying to find a group home for them that can handle somebody with serious mental illness like schizophrenia, who needs help bathing, who needs help taking meds, who needs help with everything. It's really hard. And so what we did with one of my interns, Anton Stengel, then we filed freedom of information requests in states that didn't have public information on licensed assisted living facilities or group homes. And we made a data set and published it at NIRIPS at the Machine Learning for Public Health workshop last year. And that's public data. Again, you can download the CSV with 44,000 facilities, and that has the number of beds available. And then you can start calculating revenue, because each bed pays $740 from Medicaid. Again, it's really good money. If you're in real estate or if you need some cash, you could start a group home, hire some nurses, meet the Medicaid requirements of shelter and 2 meals a day, and get $740 per person. Like this person in Fort Worth is 40 right now. They'll probably be alive another 60 years, just status quo. They've tried electroconvulsive therapy, long-acting injectable antipsychotics, clozapine, benzos, everything. They're slowly decompensating because schizophrenia is a progressive disease. So that's $740 a month for 40 years for one person for 2 meals a day. It's a pretty good deal if you think about this national level data with 44,000 facilities and little to no oversight, because again, the hospitals need to keep putting people here, so do the cops. And what do you do when you have a lot of people with behavioral health issues, sometimes with criminals? Like I found some jail rosters in Fort Worth at the same address as this person I was helping. And this is, again, public data. It just takes some digging to link the jail rosters of who gets out of prison and happens to be living with somebody with schizophrenia. And so to try to get at some of these confounders of like the data, then we can think about drawing a puzzle graph, like Dr. Prosperity's research recommends we do. So in this puzzle graph, it's a little bit hard to see, so I'll read out parts of it. Like, let's say my friend gets admitted to a hospital because there's a psychotic episode. They get admitted, the doctor might fill in things into an electronic medical record, like in Epic. Then they get discharged. And then upon discharge, then there's a billing revenue cycle team that steps in. They generate codes like CPT codes or diagnosis related group codes. Sorry, CPT is current procedural terminology codes. And then there's 2 separate processes. Sometimes a physician will code their own patients. Sometimes they'll search for codes in records. And this is such a delicate balancing act because you want to stay away from the Office of the Inspector General at the Centers for Medicare and Medicaid Services in case you get audited. So you need to balance which codes you're using too much, which codes you're underusing. Like say malnutrition is paying super well one year, you might use a lot of that if you're a billing revenue cycle team. This is such a artwork to get right. Then you have the complete code list, then you do clinical documentation improvement. Sometimes you might call a doctor and check, can I really call this like it's clinically plausible? A doctor might think that this code is slightly related. Then you get the final codes, then you send it off to insurance, and then you're in battle with insurance to try to get reimbursed or not. And so we're slowly starting to make these causal graphs to try to get at some of the confounders in this complicated landscape. So now that we saw how data flows up, how profits hopefully trickle down, if you're one of the lucky few to see those as patients, we can think about how to fix some of these incentives and start building more equitable artificial intelligence and machine learning. So what we're launching in a few months is Payless.health. It's a hospital price transparency database, because now there's a price transparency rule at the federal level, and we're using machine learning and natural language processing to annotate all the price lists, link them to health equity measures, like say proximity to assisted living facilities, or quality outcomes like readmission per zip code level. And our key performance indicator here will be median hospital price, and whether we can decrease this in the bottom quartile of median incomes across the US. We got a small grant from Columbia and Stanford University that we're working off of, and then we also are deploying our natural language processing techniques for some startups that are also involved in coding efforts to try to make clinical documentation more accurate. And one quick ask for y'all, I know I'm close to time, is which national scale quality metrics should we link to? Is that readmission or is that sepsis? And so if you have any ideas, shoot me an email. And I'm lucky to have a strong team and a strong team of advisors. So thank you so much.
Thank you so much for both of your presentations. I think it's very evident that you both emphasize the potential we have to utilize AI and ML to address health disparities and increase access to quality care. In the interest of time, we will open up the microphones for anyone from the floor, and if not, I have some questions that I can ask. So does anyone have questions they'd like to ask? Please.
Thank you, that was a great presentation. If this doesn't work out for you, the whole Woody Harrelson government. That and apparently funding major new homes across the country. So I have a couple questions, sort of related. So one, just out of curiosity, are you for or against?
I have family in Canada, that's where I was born. I was just in Estonia, where my grandma, cousins live. Some members of my family have mental health issues there. I have family in Sweden. I've lived in Australia, I've lived in England, and America is still the best system I've seen. And capitalism, it's either like, do you believe in capitalism or not? And every time I've seen a model other than capitalism, where people are self-interested and behaving as rational agents in economic terms, then I haven't seen it work out as well as it has for, say, my friend in Fort Worth. Because in Estonia, it's still slowly catching up. There's a lot of racism in Sweden as well. In Canada, it's good if you're in the middle of the bell curve, but if you're at either extreme, either lots of money or very little money, or same for rare disease, non-rare disease, then it's a lot harder. And same is true in England. Like, people love the national health services, but in terms of wait times and things like that, it's still difficult to access quality care. So I think it takes all of us thinking about what checks and balances are important to keep the system healthy, for lack of a better word. And now that we have models like Bellingcat or the Markup or ProPublica that do some mix of data analysis, transparency, reporting, I think with our efforts in health equity and machine learning, we can support those kinds of journalistic efforts to try to increase transparency and get actual laws changed. Because until laws are changed, then if I'm a CEO of a publicly traded like healthcare company like Aetna or United, then I'm driven by those quarterly earnings because of part of the law that deals with fiduciary responsibility to stakeholders. Like, if I own a share of Aetna, I own a share of United, I can go to the CEO and say, hey, I'm going to sue you because you're not doing everything you can to use all of this data to make the most money. And so that's on a quarterly basis. I think that's one example of like a part of the law where instead of fiduciary responsibility to stockholders, there might be something like fiduciary responsibility to patients who donate their data that ends up in health information exchanges or CCDAs, and that needs to be part of the law. So if AIMAHEAD is connected to Congress, then that's one example of like something that would be awesome to work at.
Got it. So we have some people. That was a segue, which gets into my second question, and one I wanted to put out. You spoke in this second one about patients, agency, and only their data in a monetary way, right? So this is something that obviously there are a lot of detractors in big business for why that should not be the case. So if you can just expand on it, so if there's something, oh, and I'm sorry, I think that is my role, I'm like, so then, I'm getting engaged in national line against disparities in patient health. So this is the area where you have great concern in a lot of, and also. Thank you.
Awesome. Thank you, Dr. Simmons. Sorry, what was the part about the patient data?
Thank you for elevating me to doctor, not yet.
Mhm.
But, I'm sorry, what was
The part about like businesses are not incentivized to compensate.
businesses are not incentivized to compensate people at the patient data level. Because right now we pay 23
Yeah.
Not the other way around, so.
Yeah, it's another good example of that is Picnic Health or some of these aggregators where if you have a rare disease that's a focus of life sciences treatment, then you can donate your clinical records, get some benefit. Kind of like the same argument the director of the NIH was making of like the benefit provided to the patient is aggregation, maybe some machine learning, maybe some synopsis of here's what maybe all of a study found out about you. And it's hard to turn that into money. I totally agree. It's hard to find the right incentive. So one thing that I'd love to do at the foundation is have an opt-in system of if somebody opts in, that's tracked in a text file, it's just 1 or 0 for everyone in the US. And if you opt in, then machine learning models can be trained on your data. And then again, back to owning things, owning your data, owning property, that might take the form of owning a license, part of a license or a share of the intellectual property that the foundation owns. It's a 501c3, it's transparent. So kind of functioning as a neutral broker of ownership of intellectual property derived from private health data or protected health information. And so that's one example of something that will take a few years to figure out, but I'm hopeful about it.
Thank you. I think we have a couple questions from the chat, or at least one. No questions. Okay, I thought someone had their hand raised. Does anyone else have questions in the last 3 minutes?
So thank you, Janana. Thank you, Nadia, for bringing out these important considerations. We understand the confounding variables and also the conflicting interests at all levels. The question is how do we address or how do we minimize those conflicting interests? Now, bottom up of now. Don't know where to start. So any thoughts on solutions?
What do you think, Dr. Prosperi? I need more time.
Also, I work less with corporations and more with the State Department of Health, so I can tell from my personal experience. As I highlighted in the talk, I think that the first thing you have to do is to see what can be done and what are possible interventions that are achievable in the short term. That's where you start building the first model. So this kind of causal structural diagrams that you can create must be real world. That's why we have conversations with the community and with state officials, because they tell us what kind of resources they have, what kind of things they can do in the next couple of years. So that helps because these low process and if you start moving things, if you start having small interventions, these interventions in fact can be amplified, and therefore you can start thinking bigger. Nothing prevents you from from planning something in the short term and in the long term. There are low-hanging fruit solutions, there are low-hanging fruit interventions for which you can use the current resources. These can change a little bit the structural disparity that is there. I mean, if we are able to increase by X% the undetectable or viral load in certain vulnerable population, it means that there are going to be less infections than vulnerable population. That's just something you want to start doing it, that rather than starting with the big picture, because anyway, that is going to be immediately measurable. It's going to help minority or rural population in any vulnerable group. And then you can start from there. It's not building the huge equity step by step. It's not something that can be done. It's what I think is starting with small steps, and I think you can.
I agree. I would just to add one more thought on that. I think starting small makes sense, and I think all of us know so much about healthcare. Some of us are lucky to have access to up-to-date clinical guidelines. I use that all the time for friends, family, people who can't get access. And if we can't get ourselves access to healthcare, we can't get ourselves access to data and ownership of data, we're never going to solve it. So I would encourage all of you to think about where in your life you can pick up the phone and just call someone and figure out, well, where's my data going? Is there machine learning being done? Is there AI being done? Because unless you can do that for yourself, you have very little hope of understanding any of these confounders that we just talked about. And the more I found myself doing that kind of first-person ethnography or qualitative research on myself, like I said, PTSD last year, I had to get 3 single case agreement exceptions denied before United was covering on 375 a week. Clinical psychologist to get better. Now I'm doing fine. But that's just an example of like, even when I was depressed, I had PTSD, panic attacks, I could still just do what I do, like do the research. All right, single case agreement exception. Here's how to do that through insurance. Here's how to argue with CPT codes, with DSM diagnoses. It's not rocket science. And we all do that in this room for ourselves, for people in our families, our communities. And I think the more we take actions like that are very direct and small scale, the more we learn about a big system. Like it's a 10 phone calls for somebody to say the words single case agreement exception. I didn't know you could get out of network coverage bumped up from $100 for reimbursement to $275, but that really got me thinking about this whole bigger picture of how much people are incentivized to hide information from you. So when you see it yourself, that's a very powerful agent for behavior change for yourself and others. So I encourage all of us to make use of that.
Thank you so much for this event.
All right, thank you to our panelists for a wonderful session. We are going to take a 5-minute break while we set up for the next panelist session. Sorry.